My pleasure to introduce Dr. Sandip Biswal. Start our recording here. And he's an associate professor in musculoskeletal radiology who comes to us from Stanford. He's just started here. Start, Sandip?
October 17th.
October. One of his major research focus are imaging of pain and musculoskeletal pain. He spent a lot of time at Stanford working with neurosurgeons there. So he's going to give us a talk on what he's asked and what he's hoping to do. Thanks for coming, Sandy. Appreciate it.
Thank you, Dr. Brooks. I'm a musculoskeletal radiologist, and it's 2003 at Stanford. And then I've been involved in this business of trying to find pain generators with a more precise, accurate technique, which I'm going to talk about. And as Dr. Brooks mentioned, I've been working with a couple of neurosurgeons in this regard, and I'll share our experiences. I'm going to be specifically talking about imaging pain generators and then giving some examples with spinal pain and CSF leak. These are my disclosures. I will be talking about the unapproved, unlabeled use of FDG, which is a PET radiotracer normally used for cancer screening and staging, but I've repurposed it for pain imaging, if you will. And as you probably know, pain is now the most prevalent disease in the world. It's the #1 reason to see your doctor, #1 reason for lost days at work, and an important cause of the opioid crisis. I don't usually like to talk about finances in terms of diseases and human suffering, but now pain outnumbers and kind of has a budget that's quite incredible. It's approaching now $1 trillion US in the management of people suffering from chronic pain. And if you take everyone with cancer, diabetes, and heart disease combined, it's still less than the aggregate amounts for those suffering from pain. So it's a quite devastating problem. It outpaced common cold in 2011 as the #1 reason to see your doctor. Again, just to kind of impress upon you how important this phenomenon is. So in my talk, I'm going to talk about the struggle I have as a radiologist and working with my referring physicians, and then talk to you about the approach that I've taken to see if we can identify pain generators more accurately, and then give you some examples in low back pain, sciatica, CSF leak, and then if I have time, I'm going to throw in our experience in patients suffering from neurofibromatosis or schwannomatosis. An important clinical question that people have asked us is, can we distinguish painful peripheral nerve sheath tumors from non-painful ones? And that would, of course, improve the outcomes of these patients undergoing that kind of surgery for the removal of those tumors. So the ugly truth, you didn't know this, but I'm giving you guys, especially the trainees, a pop quiz. Okay, this is your first quiz question. Okay, among these two images, which patient has low back pain and which one is asymptomatic? Okay, so on the left image, you know, that looks like a pretty decent sagittal MRI. That's fluid sensitive. You know, there's no spondylolisthesis or herniated discs. We probably call that a normal MRI, right? And then on the right image, you see that kind of extruded disc material at L5S1. And we would say, you know, there's herniated disc in this form of a disc extrusion. Which one is low back pain, which is asymptomatic? This happens, I kid you not, every day. Turns out both of these patients have 10 out of 10 pain, okay? I can't tell you by looking at this image which one has pain or no pain. And I struggle with this every day, and I have to go to sleep at night knowing I'm giving out these diagnoses on imaging, but not being particularly helpful. So here's another interesting quiz for you. You might have heard of modic changes in the spine, of course. And so he did this interesting study where patients presented to the ER with acute low back pain, and then he enrolled patients who had acute low back pain and then scanned them with MRI in the same visit. And everyone included in the study was people with the acute low back pain and a positive herniated disc on MR, okay? So my question to you He asked them to please come back 6 weeks later. I'm going to ask you if you still have your low back pain, and we're going to re-image your back and see if you still have that herniated disc. Okay, so at 6 weeks, you have 4 possible outcomes. Okay, so that means you have the 2 that are, somewhat straightforward, which is your back pain is gone at 6 weeks, your repeat MRI, your herniated disc is gone. That kind of makes sense, right? The next outcome that makes sense is you still have your back pain at 6 weeks, and your repeat MRI shows that you still have herniated disc. Okay. Now the 2 other funky ones are you still have back pain, but your repeat MRI shows you have no herniated disc. And the other one is that your back pain is gone at 6 weeks, but on imaging, you still have a herniated disc. Which of these was the most likely outcome? Anybody want to guess? Is your quiz number 2? You can blurt out if you want, or must think to yourself. Turns out all these outcomes are equally likely. So again, I see this every day, maybe 10s, maybe 20 times a day, where I'm looking at herniated disc. I have no idea if that has anything to do with the price of rice in China. Okay, so it's very frustrating to me. I can't tell you. And that study showed, there are people with discs who are not having any pain. So, and this is not, of course, unique to the spine world. We see this in the joint world. So this is an interesting result that was published in the England Journal of Medicine about a decade ago, which scanned thousands of patients, including those with knee pain and those without knee pain. And one of the interesting things they found is that if you're 50 and above, they asked, what are your chances of having a meniscal tear if you have knee pain? And meniscal tear is considered an important pain generator of the knee, right? Almost every orthopedic surgeon is immediately doing a meniscectomy right after they get that report from us saying they have a meniscal tear. And the other big cause of knee pain would be osteoarthritis. Those are probably your 2 biggest drivers of arthroscopic surgery, right? Well, they wanted to know if you're 50 and above and you have knee pain, what are your chances of having a meniscal tear? It turns out to be 63%. Okay, what if you're 50 and above and you have no knee pain? What's your chances of having a meniscal tear? Well, you're kind of on to me. Yep, 61%. So again, probably 20 times a day I'm describing meniscal tears, but I have no idea it has anything to do with their pain. And to me, that's a little, I'm sending these patients indirectly, if you will, to their surgery, right? And then the good people of Finland donated their knees to science. There's about 200 some odd patients enrolled in this. Half of them were given an actual meniscectomy for their meniscal tear, and the other half were given sham surgery. So they actually put the scopes in, blew some saline around, and pulled the scopes out for the sham surgery group. I don't think you could ever get United States, Americans to do that study. But here they did in Finland, and as you probably guessed, at 12 months, there was no difference between sham surgery and meniscectomy. So again, for me, kind of growing up in the system, it's kind of scary that I'm doling out diagnoses that may or may not be helpful. So no difference. So what's a new approach that we could do? Well, I just kind of explained this morphologic imaging, which we mainly base a lot of our diagnosis on, like MRI, CAT scans, X-rays, really just doesn't cut it. So is there some way we could exploit nociceptive, inflammatory, or painful inflammatory molecular and cellular markers? And if there's anything you take home today, positron emission tomography is a way of looking at molecules that you're interested in, and it's about 100 to 1,000 times more sensitive than MR. So already you have like an advantage using this technology. It may not be as crisp as an MR image, but it'll give you kind of a molecular map of where things are happening. And pardon my little cartoon here, but just to remind you days from medical school, this is the nociceptive pathway. If you have a painful stimulus, you generate an action potential that goes on the peripheral sensing neuron up the corotothalamic spinal tract. You react by feeling pain, and then your brain does a lot of work trying to modulate that experience. But really smart people who study pain neurobiology learn that there's significant biochemical, cellular, and molecular changes that happen along this whole relay system, okay? And it's not just nerves that are now thought to be implicated in the pain phenotype. It's these other cells like muscles, synovium, blood vessels, uh, the innate immune system, so macrophages and your white blood cells, are now playing a very important role in the perpetuation and generation of chronic pain. So out in the periphery. So if you could develop a probe that you radio label that could specifically look at any one of these kind of targets, then maybe you have a better way, a more accurate way of looking at pain. Okay. And let's say, for example, someone came in with left foot pain. The idea was that you would take your pain-specific radio tracer, and you would inject it. It would kind of swim around. It would look for that molecular or cellular phenotype with high degree of specificity, and then you would scan them with a PET scan. And here you have a PET MR, so you could do a PET MR scan, so you get a nice MR image with a superimposed PET image, and let's say it revealed actually the pain generator is in the knee, not in the foot. And of course, the idea would be that would inform your management of that patient, right, and get a better outcome. So what I've been doing now for the past 10 years in clinical trials is doing this approach with a couple of different radio tracers, which I'll talk about in a second. But just to let you know, because you can have pain in one part of your body, but the pathology, is in a different part of the body, because what we refer to as referred pain, I scan the entire body. So from head to toe. If you have back pain, I'm still scanning head to toe. You never know where that back pain is really coming from. And we just want to make sure we capture it since the patient is undergoing this kind of experimental study. And then we'll go back and we'll try to guess where we think the pathology is and do very high resolution MR and PET imaging in another subset of imaging stations. So if, say, somebody had knee pain, we'd scan the entire whole body, which takes about 20 minutes. And then we spend the next hour imaging. Let's say if they had knee pain, we'd go from the hip all the way down to the ankle with very high resolution MR sequences, as well as getting another PET image. All right, moving on to our clinical examples. We're going to first show you some examples of using repurposing FDG, which is normally used as a cancer imaging agent, in patients with sciatica. And so why should FDG work? Well, FDG is really just a fancy radio-labeled sugar, and it's a marker of inflammation and increased metabolism. So the idea would be maybe you could see inflammatory changes that might be related to that patient's presentation of sciatica. And here I'm going to show you 3 cases where the first patient has classic sciatica, which you think of as the herniated disc and the impingement of a nerve in the lateral recess and the ensuing kind of leg discomfort that you get along with the back pain. And then there are 2 other ones that were given the formal diagnosis of sciatica, treated like this for years until they had this scan. Here is a coronal image through the lumbosacral spine, and what this white arrow is pointing to is low signal intensity material that seems to be obscuring the S1 nerve root. So it's a disc herniation that's compressing the S1 nerve root here. This middle image is the FDG image PET, showing you there's a focus of focal uptake there. You do see some normal physiologic uptake in other parts of the body that we really should not be seeing in that particular location. And then the fused PET MR image shows that focus of increased uptake occurs right at that disc herniation, which is not surprising, but kind of neat to see for the first time. So what we're seeing here are axial images through that same abnormal finding. So we have our herniated disc being kind of outlined here by red arrowheads. Here's that traversing S1 nerve root in the lateral recess getting crushed by this disc. Compare that to the contralateral side where you see kind of the traversing left-sided S1 nerve root kind of normally moving within that subarticular zone. And then the FDG PET image shown here. And then when it's overlaid on the MR image, you see that the FDG uptake is not only in the compressed nerve root, but also in the herniated disc, which my referring colleagues were kind of impressed by. They were not expecting there to be increased metabolism in the herniated disc material itself, but they thought that was kind of an interesting finding. What's also interesting in this patient is that they had the kind of characteristic leg pain that goes with sciatica. And I'm just pointing here to an anatomic image looking at the biceps femoris muscle. And this is kind of where the patient actually described their symptoms, kind of posterolateral discomfort on the right thigh, What's interesting on these fluid sensitive MR images, we don't see any changes, but the FDG PET is actually picking up muscular changes related to maybe some inflammation going in the muscles as a result of that neuropathic injury. So here on the superimposed image, that's in that biceps femoris. Here is a coronal image of the same patient, again, kind of mapping out where their symptoms are in their leg. So again, this is a classic sciatica picture, but now we're moving on to case number 2. So the referring doc in this case was getting an annual MRI scan and treating this patient like sciatica, and actually treating them with transforaminal epidural steroid injections to treat their leg pain on the left. But always was unimpressed by the MR. And so he enrolled her into the study. And lo and behold, we see a normal kind of PET image, meaning there's really not much uptake in the spinal canal region or in the nerve foramina. We do have some normal physiologic uptake in the vertebral marrow. But pretty normal looking PET scan, normal looking MR scan, which is what he also professed, that the MRs were normal. But every time we treat her with the transforaminal, she'd feel better. So he just kept doing it for a couple of years. But then enrolling her in the study revealed a lesion here in her calf muscle. And as I mentioned, we do a whole body image so as to maybe capture everything going on in that patient. And she, after she jumped off the scanner, we palpated the skin and she was quite numb there. And then she recalled this all started with the fact that she had a ski injury. The back of the contralateral ski clipped her left calf, and she had excruciating calf pain for a few months, but then that subsided, but was followed by the back pain. And so what the thinking is now is this was a scar neuroma, and she has a little bit of congenital spinal stenosis in her back. So that nerve serving this neuroma was a little bit swollen. And so she was thought to maybe have a little bit of stenosis in her spine with a kind of swollen peripheral nerve root as a result of this scar neuroma. And these are just kind of detailed images showing this kind of small focal lesion here. And we're talking to her about getting this scar neuroma treated in her calf. And then this last case, orthopedic surgeon was kind of giving up on treating this patient's sciatica, and was going to send her to, the customary path of death, which is I'm sending you to the pain clinic, right? Because I don't really have anything else to offer you. And so, but he said, why don't we try this clinical trial, and we'll put you in there so if you see anything. And this is the axial image obtained on our study. And you could argue, maybe these facet joints are a little bit arthritic. The orthopedic surgeon dealing with her didn't think it was that impressive. Spinal canal looks quite open, and the nerve foramina, which of course I'm not really showing here, were not important. But then here's the FDG scape, again showing kind of all this uptake asymmetrically behind the vertebral body. And then when you fuse these images together, you see there's a lot of perifacet inflammation. So what's kind of intriguing too is there's this exiting nerve root that's running up against this hot and inflamed facet, if you will. We can talk about, or you guys can educate me, how that might affect a nerve root passing by it. How does this perifacet inflammation affect it? But it is kind of intriguing that that inflammation kind of runs into that nerve as it passes by it. So, 3 different cases. Classic sciatica was treated conservatively. The peripheral nerve injury, the scar neuroma, is considering surgery for the removal of that scar neuroma. And then this last patient is now going to get a facetectomy. So very different, outcomes based potentially based on this kind of personalized imaging, if you will, thanks to PET-MR. FDG can also be used with CSF leak. So I worked with Ian Carroll at Stanford. As you know, CSF leak is a quite incapacitating condition arising from a tear or a hole in the dural membrane surrounding the spinal cord. Often they're undetected, and our current measures or methods of detecting where the CSF leak are quite insensitive and poor. As you all know, I'm sure, CSF is pro-inflammatory outside of the dural layer, so it's quite incites quite a reaction in the tissues surrounding the dural sac. So our goal is to determine whether FDG, being a marker of inflammation, can be used indirectly to show where CSF leak is. So in this publication, we showed there were 6 patients with suspected CSF leak and a negative workup with standard diagnostics, and we compared them to 6 asymptomatic controls. They all received FDG as their tracer and then a variety of imaging sequences. The results so far showed that increased FDG uptake was seen in the paraspinal muscles compared to asymptomatic controls, which was statistically significant. 2 out of these 6 patients were treated with a new blood patch based on the level of the abnormality seen on FDG PET-MR, and they did better than they had ever done previously based on kind of empiric treatments with blood patch therapy. What was also interesting is all the patients showed abnormalities on PET-MR, but none of the conventional imaging done prior to the PET-MR showed any abnormalities. And then 3 of the 6 patients on the MR that we employed, which is a little bit higher resolution and arguably a little more sensitive for edema, saw 3 out of 6 saw positive findings on the MR we performed, in addition to the 6 that were seen on PET. So here's an example, which was a patient who had been seen with conventional methods as being negative, but then our MR was able to detect some abnormal signal here. And lo and behold, the FDG is kind of revealing this hypermetabolic focus here at L45. This is another patient, same patient, sorry, just in the sagittal plane. For some reason, the conventional MR methods didn't really reveal this kind of fluid here, but that coincides to increased FDG uptake at this level. And so this was thought to be at the level of the patient's CSF leak. Here's another patient now. This one, I believe, was seen on conventional MR, this little fluid collection, but it was thought to be just a post-operative fluid collection, so a simple seroma. But FDG actually revealed quite hypermetabolic and avid and FDG uptake. So theoretically, a seroma should not be FDG avid, or it should be just barely over background. But this is quite robust uptake. So this, again, supported perhaps the presence of a small CSF leak with FDG avid fluid collection. And then here's another patient who had a laminectomy. Again, they had trouble figuring out what was causing the pain. And the laminectomy had happened about 2 years prior to this image, but still a fair amount of FDG avidity here, which I would think would be perhaps a little bit more than you would expect 2 years out. So we did get some kind of not slam dunk type of imaging, if you will, meaning we do see this uptake in this patient's paraspinal muscles up in the cervical spine. The fluid sensitive sequence showed no abnormal muscle signal, but the FDG revealed it. And you could argue maybe this is due to muscular activity in the patient's neck. But compared to asymptomatic controls, asymptomatic patients typically don't have this kind of uptake in that pattern. And whether this represents CSF leak is hard to prove definitively, but the patient underwent a blood patch here and did better. This is just coronal images of that same patient, showing again how a fluid sensitive sequence won't pick it up, but the FDG is picking up some abnormal uptake at that level, kind of raising suspicion maybe something's wrong at that level. Here's a couple of patients that did better with the new imaging. So unfortunately, these blood patches are sometimes, or most of the time, transient in their relief. So this patient 1 had, for the first time, experienced relief based on the imaging findings we were able to present. And patient 2 felt also better, having undergone several blood patches in the past. So increased FDG uptake is seen in patients, the paraspinal muscles of patients with suspected CSF leak. It may be more sensitive than conventional MR, and but note that the FDG uptake may be nonspecific and related to prior surgery. So you just have to take that into consideration. And then it has the potential to better localize the level of treatment in terms of epidural blood patches or any of the glutes that are out there commercial. This is the other tracer that we're working with. It's a sigma-1 receptor radioligand. And as I kind of mentioned in these last cases, FDG is relatively nonspecific. It kind of raises some questions about what we're doing. The sigma-1 receptor is a chaperone protein whose expression is increased when cell has increased electrical and signaling demands, especially due to painful inflammatory changes. And so here's a little cartoon I've created to kind of illustrate what it does. The sigma-1 receptor normally resides in low levels at the endoplasmic reticulum, and they usually buddy up to one of these ion channels that are important in cell signaling, especially in kind of electro potential generation. So a lot of the channels they may buddy up to are like NMDA or voltage-gated calcium channels, voltage-gated sodium channels, the TRP channels, but they just kind of hang out here in low levels, and then you have some inciting event, some injury, and then the cells, when they sense all that, they increase the copy number of the sigma-1 receptor. And then their role is to actually chaperone these ion channels up to the cell membrane, and then they help them do their thing. So we get like a robust increase in the receptor at the site of insult. So this is kind of what I'm trying to exploit, is a radio tracer that binds to this receptor. And the fact that you can see it over background is because the sigma-1 receptor now has been overexpressed in that local area of pain generation. And what's also interesting, it's considered a receptor because if you antagonize this receptor, it'll actually modulate the function of these proteins. So not only does it carry these ion channels up to the cell membrane, it actually changes their behavior whether you antagonize or agonize these receptors. So there's a lot of talking between the channels and this receptor, and you can actually achieve analgesia by blocking this receptor. So it's an analgesic in itself. There are a lot of really smart people that have figured out what it does, and I've kind of illustrated in this style. And they all, in an elevated amounts, it contributes, unfortunately, to pathologic pain by increasing sensitization and long-term potentiation. It enhances neurotransmitter release and responses of various ion chains. Our group invented this small molecule, which we put a PET emitting isotope. So now you can see this molecule with PET, and this is what is highly specific for that receptor that I just spoke about. This is kind of an outdated slide. We're around 190 some patients that we've scanned with this tracer. In terms of patients with chronic pain, if you just look at the MRI alone, only about a fifth of them will show an abnormality on MRI, whereas nearly 100% of the patients on PET will see an abnormality with the sigma-1 receptor radioligand. And this has resulted in about 70% change in management for these patients. And at the time of this slide, 11 out of 38 had seen improved outcomes based on these management changes. And these are patients who kind of failed the system already. In terms of asymptomatic volunteers, what was interesting is none of the patients have any MR abnormality, and one patient actually had a abnormality on PET, and the patient failed to tell us that they were wall climbing the day before. I forget there's a better word for it, but scaling these walls as a workout, and he was quite sore from it. So after the scan, we kind of noticed it, and we asked him what were you doing, and he said, "Yeah, I was climbing walls all day yesterday." So he was busted. He's not truly asymptomatic. And then as soon as we got FDA approval to insert these into human subjects, the first thing we wanted to know is, okay, can we find a painful nerve lesion and see if we can image it with a degree of positivity? And here we have a peripheral nerve sheath tumor in the sciatic nerve shown here on MR imaging, and then this is our sigma-1 receptor PET, which shows some avid uptake. This nerve lesion was subsequently removed, and the patient had no pain afterwards. So this was a good kind of supporting finding that this tracer is doing what it's supposed to do. And then we also wanted to find a nerve lesion that was non-painful. So this volunteer had a sural nerve biopsy and an ensuing neuroma after that, unfortunately. Fortunately, it was not painful. In fact, I mashed on it myself. It was right under the skin. The patient reported no pain, and he was nice enough to volunteer for the study. And then when we gave him the tracer, you can see at the site of the neuroma and also on the hybrid image, there's just no uptake of this tracer. So that was kind of nice. I know this is not really neurosurgery related, but just to kind of give you an example of kind of the results we're getting. This is someone who had an ACL reconstruction and then had extreme pain after it. This is the diagram that they drew on where their pain was, so in their left knee is where they had the surgery. This is our whole body sigma-1 receptor ligand PET image showing you where their pain was, which is kind of corroborating where the patient's symptoms are. This is a little bit more zoomed in image. And then these are just kind of sample MR and PET-MR images showing you where the uptake in that knee is. So here it's kind of in the vicinity of the fat pad between the distal femoral condyle and the patellar tendon. So a lot of uptake here anteriorly in the knee, also some more posteriorly. So a lot of that is quite abnormal. A patient with no knee pain would have none of this here. It would just kind of look like the background signal that you see in the lower part of the image. Again, this was thought to be what's called arthrofibrosis, which is an unfortunate outcome in a subset of patients with ACL repair, and it was painful arthrofibrosis. So what we're seeing here, pre-surgery, so this is after ACL surgery and lots of pain. He had 10 out of 10 excruciating pain. He couldn't do any of the athletic stuff he used to do. He finally convinced the surgeon to go, and his initial surgeon who did the ACL repair, interestingly said, the MRs just show normal post-surgical change. I have nothing else to offer you. It was actually quite annoyed with the patient and refused to treat him any further. So we managed to convince another surgeon, can you go in there and do a synovectomy and kind of a cleanup of all these areas that shows positive on the tracer image. And this is the post-synovectomy image and showing you kind of removal of that kind of painful tissue, and the patient actually now reports 0 out of 10 pain in that knee, and it actually feels stronger than the contralateral knee as he's been able to get it back to full strength. This is a patient, 36-year-old, was out motorcycling in a national park and accidentally fell over a rock and landed on his back about a couple stories below him. So went over the cliff basically. This is their pain after the incident that was there chronically, and had seen many doctors. Nobody had been able to relieve the pain. Here we show on this axial image through the spine, there's a fracture of a transverse process. He actually had a whole series of these in sequence from, I believe, L2 to L4. There was fractured transverse spines, but if you were to palpate it or push on his back at each level, only one of them really solicited a painful response. And it turned out to be this one, where the sigma-1 tracer is getting up right up to the fracture. Compare that to the non-painful fracture. Here's one that's non-painful, and that corresponds to this kind of area on the transverse spine. So again, kind of nice corroboration between where pain is and where the morphologic imaging is. And then the flank pain we couldn't really understand until we looked really carefully in the subcutaneous tissue. So if you look here on this PET image, you see this little focus here up to the patient's left flank in the subcutaneous tissues, which the patient was having a lot of pain. Compare that to the contralateral side as a kind of internal control. And if we take a zoomed in image, maybe there's an unnamed nerve that has a little neuroma there. But that kind of corresponds to an area of increased radiotracer uptake. So after we saw this image, we offered to inject that site with Marcaine. And pre-injection, the patient had a pain of 2 at rest, and then if he would exercise, it'd get up to like 4, 5, or 6. And then after the injection, the patient reported no pain there, even after a hike. So kind of a nice result showing that we could alleviate that patient's pain by locally injecting, at least temporarily, some relief. And it had been like the first time the patient had any relief from their pain, which occurred about 8 months prior to this injury. I'm working with Dr. Anand Veeravagu. I'm not sure if you guys know him, but really wonderful individual. He's been now sending me patients with low back pain, and here are just some representative images from this collection of patients. So here in column A, we have uptake in the nerve foramina as well as one of the facets, but not so much in the contralateral facet. So this is kind of helping him kind of tailor each patient's pain experience. Here's a patient with bilateral facet injury, or at least arthritis. This is that painful transverse process fracture and that flank pain. And then some patients have a pristine looking spine, but it turns out their paraspinal muscles are actually the culprit in this case. So this is also helping him decide not to do surgery, for example, and maybe provide some therapy for the paraspinal and the muscles primarily. But we're just about to submit a paper with our experience on this. What time is it? I think I have a couple minutes. Peripheral nerve sheath tumors, as I mentioned, patients with multiple peripheral nerve sheath tumors is a diagnostic challenge in terms of determining which ones are painful and non-painful. So Dr. Wilson here, who I worked with for a number of years, has now implemented this tracer, the sigma-1 receptor ligand, to see if you can distinguish painful from non-painful. Here's some of the images we've obtained. This is a non-painful peripheral nerve sheath tumor in the brachial plexus. So we see kind of the brachial plexus nerves. We can even see some kind of wrapping around this particular schwannoma. And then on sigma-1 PET, not much uptake there. So non-painful. We can make quantitative measurements. So we measure these things called standard uptake value. So we can make this, a statistically significant kind of approach here. And here's a patient with a very painful sciatic nerve peripheral nerve sheath tumor. And we do this kind of MR neurographic sequence in addition to the PET. But here's our peripheral nerve sheath tumor. This was a SUV max of 3.2. In this particular patient shown here from the fused image. Here's a patient with, in the top row is one patient. They had schwannomatosis, so multiple schwannomas in their body. And Dr. Wilson's trying to determine which ones to take out, because taking out all of them would be quite morbid, of course. So if you could minimize that or be more accurate, then you could do the patient better. So here's a severely painful peripheral nerve sheath tumor in the ulnar nerve with a SUV max of 3.79 on the visual analog scale, had a number of 62. This was a less painful one after mashing on it, a visual analog scale of 25, and then the SUV of 2.47. This is a different patient on the bottom row showing a painful peripheral nerve sheath tumor of the posterior femoral cutaneous nerve. Again, VAS score 65 and a SUV max of 3.7 compared to a less painful one in the same leg of the sciatic nerve with a VAS of 24 and an SUV max of 2.4. So Dr. Wilson chose to remove this one, and the patient's pain in that leg dropped from a VAS of 65 down to 8. So quite a remarkable change just by simply removing one of these tumors. He found that the threshold between painful and non-painful is an SUV max of 3.12. If you use that as your threshold, you have a sensitivity of 100%, specificity of 87%, and accuracy of 92%. And we found a pretty strong correlation of 0.64. Really quick, I'm also looking at kind of immune-mediated painful syndromes. This is an unfortunate patient suffering from Sjogren's disease, which is this clinical syndrome where you have migrating extremity pain as well as dry eyes and dry mouth. Here's her figure. She's basically putting it everywhere around her. No imaging up until this point was able to show anything positive. So as you can imagine, she's been quite frustrated because doctors have been not believing her. She's also been not believing herself. This is her image on the left with the sigma-1 receptor, and these are two asymptomatic volunteers showing you what typical distribution. There's some physiologic uptake in the veins as well as the lung, but here's her extremities kind of showing you quite robust uptake of this tracer, unfortunately for her. Here's some just represented fluid sensitive sequences showing you the neck, which are negative on our MR imaging, but quite positive on the PET imaging, and directly correlating to where she's having symptoms. In an email exchange, she had mentioned it's good for me to know where I hurt as an imaging correlate finally, and that's not all in my head has been suggested. You have helped me more than you know. So now she's kind of showing these images to her doctors, and now I think they're taking her more seriously. So in summary, this is a kind of new approach to image pain with PEMR. I'm hoping to build on this here at Wisconsin. It's a big reason I came here. The Department of Radiology has been generous to help me develop 4 new tracers for pain imaging. So I'm going to be looking at 4 different molecular targets. I'm happy to collaborate with anyone here. PET sensitivity, I think, is quite important in this endeavor. And I think MR still provides an important role morphologically. So sometimes if we can do very high resolution MR in the area of PET abnormality, it may be able to, determine maybe there's something surgical or non-surgical at that site. I really think using this whole body approach is quite helpful since it may reveal sources of pain not known previously. A number of people that I work with have been very helpful along this stuff. And thank you for your attention.
Thanks, Sandip.
Yeah.
We've been in terms of the peripheral nerve tumors. I've seen one of the things, figuring out which one's painful is usually pretty easy because they point to it and say this is one. But the question that comes up in clinic is does this mean that there's been a transformation of this relate to determining, in an NF patient, whether or not the tumor is turned malignant?
That's a great question. The short answer is no, not currently, but that could be certainly a direction that I'm sure Dr. Wilson would like to get into. There's some evidence that the sigma-1 receptor upregulation is increased in tumors that are about to become metastatic in different tumors.
Attention, your attention please. We'll be conducting a test of the fire alarm system. This is only a test. This may take up to an hour to complete. Attention please. We'll be conducting a test of the fire alarm system. This is only a test. Again, this may take up to an hour to complete. Thank you.
I think questions are going to be difficult.
Thanks, Sandip. Great talk. Are these available for us to order now or not yet?
The sigma-1 is not available here yet, but there's radiomanganese that we're about to get approval for here. So manganese is M2+. It looks very similar to calcium 2+. So it actually uses the same channels that calcium gets in. So I'm using a surrogate marker for calcium fluxes. So any neuronal populations that are transmitting a lot of electrical messages should be sucking in manganese as well as calcium. So the idea is that injured nerves or neuronas and potentially angry peripheral nerve sheath tumors will be sucking it in. But hopefully next month we'll get approval from your IRB or my IRB.
Is this going to be available for us to order in Epic or?
No, this is you have to email me or my collaborators.
Got it.
But I will certainly be canvassing your emails with, hey,